Hello, and thank you for joining today's virtual panel, How to Counsel Your Patients, Insights on NACI's latest HPV vaccine recommendations in Canada. We're excited to have you with us for this important discussion. I'm Antonella Pucci, the Manager of Immunization Initiatives at the Canadian Public Health Association, where I oversee Immunize Canada, a national coalition of non-governmental, professional, health, government, and private sector organizations dedicated to promoting the benefits of immunization across the country. On behalf of CPHA, it is our pleasure to host this virtual panel for healthcare professionals today. Before we begin, we would like to acknowledge that the Canadian Public Health Association's office is situated on the ancestral and unceded territory of the Algonquin Anishinaabe people. They have been the guardians of this land for millennia, and we are grateful for the example their stewardship provides. CPHA is committed to working with all First Nations, Inuit, and Métis peoples and their governments in realizing meaningful truth and reconciliation. As for disclosure, this project is made possible with the financial support of Merck Canada Inc. through an unrestricted sponsorship. The opinions expressed in this presentation are those of CPHA and the panelists and do not necessarily reflect the views or opinions of Merck. As for some housekeeping notes, this virtual panel is being recorded on Zoom. A recording of this virtual panel will be made available on immunize.ca and on our YouTube channel shortly after. If you have any questions regarding technical difficulties, please contact Immunize at cpha.ca or directly message myself, Antonella Pucci, or Danielle McPherson in the chat, and we will reply to you as soon as we can. If multiple people are experiencing the same problem, we'll address it live via a broadcast chat, via a broadcast message in the chat. That being said, the host will use the chat tab for extra communication to participants, so please keep an eye on that as well. As for the questions and answer session, you are welcome to submit or upvote questions for the panelists in the Q&A tab at any point during this panel, and they will be answered at the end of the presentation. Due to time limitations, not all questions can be answered. Finally, we would love to hear your feedback, so please fill out a 5-minute short evaluation survey upon exiting the Zoom platform, and we'll be sending it via email as well. Now, I'd like to turn the floor over to our virtual panel moderator, Ian Colbert, the Executive Director of the Canadian Public Health Association.
Thank you so much, Antonella. Welcome, everyone, and thank you for joining today's webinar on counseling patients about the HPV vaccine in light of the latest recommendations from the National Advisory Committee on Immunization. This webinar aims to enhance healthcare professionals' awareness of NACI's current HPV vaccine recommendations, the limitations and ethical complexities of the new single-dose HPV vaccine recommendations, and key considerations for effectively counseling patients, parents, and guardians about the vaccine, including its role in preventing not only HPV-related reproductive cancers, but also HPV-related head and neck cancers. With that, I am delighted to introduce you to our three panelists, Drs. Daniel Warshawski, Nancy Durand, and Cheryl Cable. Dr. Daniel Warshawski is a public health and sports medicine physician. He currently serves as the Associate Chief Medical Officer of Health, overseeing the immunization portfolio within the Office of the Chief Medical Officer of Health at Ontario's Ministry of Health. Additionally, he holds the position of Assistant Professor in the Department of Family and Community Medicine at Queen's University and is an adjunct professor at the University of Ottawa. Next, Dr. Nancy Durand is an associate professor in the Department of Obstetrics and Gynecology at the University of Toronto. She earned her medical degree from McGill University in Montreal, where she also completed her residency in obstetrics and gynecology. Dr. Durand is on staff at Sunnybrook Health Sciences Centre in Toronto, specializing in colposcopy within the Department of Obstetrics and Gynecology. Her primary area of interest is the prevention of HPV-related diseases and cancers through HPV vaccination. An international key opinion leader and speaker, she advocates for adult HPV vaccination in both females and males to reduce the burden of HPV-related diseases. Last but not least, Dr. Cheryl Cable is a I knew I was going to mess this up. I told Dr. Cable I would. Prosthodontist and maxillofacial prosthodontist. She is an internationally recognized leader and influencer in the field of head and neck cancer and maxillofacial prosthodontics. Previously a professor at the University of Alberta in the Faculty of Medicine and Dentistry, Dr. Cable is currently the lead of oral and maxillofacial care and research at Covenant Health in Alberta. Dr. Cable completed her undergraduate Bachelor of Science and Doctor of Dental Surgery degrees at the University of Alberta and received her prosthodontics and maxillofacial prosthodontics certifications at the Mayo Clinic in Rochester, Minnesota. A past president of various dental and specialty groups in Alberta, she has collaborated with the Alberta Dental Association and College and the College of Dental Surgeons of Alberta on several committees. Dr. Cable has worked with Alberta Health on the oral and maxillofacial devices and services program and has served as an examiner for the Royal College of Dentists of Canada for dental specialists. She is also the lead of the Alberta Head and Neck Cancer Dental Leadership Team. So with that, I will turn it over to Dr. Warshawski for his presentation.
Great. Thank you so much, and thanks for having me today. So we can jump right in. Next slide, please. So just no conflicts. Glad to be here. Next slide. So I'm going to cover a pretty high level just overview today of HPV immunization and infection in Canada, and Dr. Durand and Dr. Cable are getting into much more detail. So mine's just the primer for us, if we can start with that one. So next slide, please. So HPV, it's a sexually transmitted infection. It's extremely common. So in individuals who are unvaccinated, about 75% of sexually active people will be getting an HPV infection at least once in their lifetime. Obviously, once we reach the level of herd immunity with the HPV vaccine, we'll see less and less of this happening with the strains that are covered. But certainly it's still quite common at this point in time. Most people who get an infection, they don't have immediate symptoms. It can cause things like anogenital warts, but not everyone will get that right away. It's a minority, but it's the persistent infections that lead to those serious health outcomes that we're talking about today, particularly cancers. HPV vaccine is one of the few we have that is a cancer-preventing vaccine. HPV itself, there are over 100 different strains. So the vaccine, of course, at this time doesn't cover all 100 strains, but they do cover the most common strains that are cancer-causing. So at least within Canada, HPV 16 and 18 cause 70% of all cervical cancers. And some of the other strains that we have covered in the vaccine, so HPV 6 and 11 cause 90% of anogenital warts. So, again, very, very common infection, and the outcomes are something that are quite significant that we follow. Next slide, please. So the vaccine itself. So at current times, most provinces and territories are using primarily the non-valent vaccine. So it covers 9 different strains of HPV. The numbers are all listed there. And it's very, very effective. So the data we have to date shows that the vaccine is essentially 100% effective at preventing cervical cancer caused by HPV 16 and 18, and 95% at preventing vaccine strain-related genital lesions. So this is top notch in terms of the types of vaccines we have available, the level of effectiveness that we see, which is really wonderful. The vaccine basically works by having coding for the viral capsid. So you can see the nice picture here with the major capsid protein. The capsid for HPV just naturally forms with those single particles into the overall capsid. So what happens when you have the vaccine is that it forms basically what looks exactly like an HPV virus infection, but it doesn't have any actual infective DNA within the virus itself. So again, that's why it's very, very effective at creating a really good level of immune response. Within Canada, we have targets of achieving 90% HPV vaccine coverage by age 17 to support cervical elimination overall. And at this point in time, all PTs do have a gender-neutral, all provinces and territories have a gender-neutral HPV program for school-age children. And I'll show a little more about that later. So next slide. So here's the quick summary, and this is from the Canadian Partnership Against Cancer. This is based on 2022, but it's still accurate, and I just made the note of the only change we've really seen since then. So again, all provinces and territories at this point in time are covering with the Gardasil 9, so the non-valent vaccine that we have available. The age that they start administration slightly differs, some grade 6, some grade 7, some grade 4. It is a little bit different based on the province and territory, but all provinces are covering this for both males and females. The major change has really been that Quebec just as of last year moved to also to have the reduced one-dose schedule based on NACI recommendations. Other provinces and territories are all still using the previous 2 or 3 dose schedule that was recommended. Obviously, the vaccine is also available in the private market for individuals who don't fall under the eligibility still in the provinces and territories. The cost for that vaccine is anywhere from around $500 to $600 if someone's going to private purchase. So it does remain widely available, and again, the programs in the different provinces and territories cover the majority of people. If we go to the next slide, please. Unfortunately, the coverage rates that we have are not hitting that national 90% target. So this is a little bit out of date. It's 2020 data. What I can say is that what we've seen in the time since 2020 is not huge increases. So of course, over the time of the COVID pandemic, we saw decreases in immunization rates across the board, not just for HPV vaccine, because of limited access to healthcare. Kids weren't even in schools physically for some of the time. So it did limit the ability to uptake. There has been a bounce back, but we haven't really seen huge gains in HPV immunization across any of the provinces or territories. So this slide is just showing what our uptake rates are for females as of 2020. And if you go to the next slide, please. This is looking at that same but for males. So fewer provinces, including this one, just because some of the provinces and territories had just started their programs around this time. But again, you can see that most provinces and territories are not at and not particularly near hitting that national target of 90% that we're aiming for elimination. Next slide, please. This one I thought interesting to compare. So this is just the Ontario-based data. And what this is comparing is all of the school-based vaccines. So you have hepatitis B vaccine on the left, HPV vaccine in the middle, and our meningococcal vaccine on the right. I mean, one thing to note is obviously we're not hitting those national targets for any of them in Ontario, something that we're certainly working on. But you can see that HPV still remains the lowest uptake out of any of the school-based products that we have. Part of that is depending on how many doses you need. So if you only need a 1-dose schedule, uptake will automatically go up because some people are not getting both doses, but still remains at the bottom in terms of our coverage for a whole host of reasons. Next slide, please. So I want to talk about now is a little bit on the decision-making process that we have in provinces and territories about how these programs are operated and changes the programs are made. Because it's a lengthy process that takes many, many years before there is a change in any particular vaccine program. It obviously starts with the manufacturers and producers of different immunization products. They will be submitting to Health Canada for approval of the product, and that can take months to years, sometimes for a product to be finally approved by Health Canada. Once Health Canada does authorize that product for use, then it would go to our National Advisory Committee on Immunization, or NACI, to give national advice based on their scientific expertise on what is the best use of that particular product across Canada. Sometimes they're leaving more room for local epidemiology-based responses as well. Sometimes it's broad recommendations for the entire country. After going to NACI, it'll go to groups like our Canadian Immunization Committee. This is where provinces and territories meet to discuss their immunization programs and talk about more program implementation, as opposed to specifically the scientific and technical advice on it. Within Ontario, it then goes to our Public Health Ontario for Ontario-specific recommendations. That would include our Ontario Immunization Advisory Committee, which is something Ontario has. A number of other provinces and territories have immunization advisory committees as well, and that's again part of the process, before finally going to the Ministry of Health, which is ultimately making the decisions in provinces and territories about what is actually the policy and funding for any particular immunization. So next slide, please. So again, just quickly on what those groups are. So NACI, they're issuing scientific recommendations. They have a very thorough framework they use. They recently started incorporating things like cost effectiveness into the recommendations as well, which is super, super helpful for us to see. And they publish things like the Canadian Immunization Guide, which is an evergreen document they continually update based on new evidence, new products, new recommendations coming out from NACI. Again, that Canadian Immunization Committee, that's made up of federal, provincial, territorial representatives, and it's looking at more things like program implementation as opposed to the science of those particular products. Next slide. And then we get again into places like Public Health Ontario, providing Ontario province and territory specific advice based on local epidemiology, demographics, operations of how programs exist right now in that particular area. And then finally, again, over to Ministry of Health, whether it's Ontario or elsewhere, for decisions on actual funding and program implementation. Next slide, please. And I'm sure everyone's familiar with this one. This is the Erickson-Dewalls-Ferrand criteria. But this is broadly what all of these groups are looking at in terms of should we have a publicly funded program and what should be covered in that publicly funded program. So these criteria that were developed by Erickson, DeWalls, and Ferrand look at the broad swath of things. I'm not going to read them out to everybody, but these are all the different types of considerations we might have about how are we best and able to make any program changes or make new programs to any immunization that we do have right now. Next slide. And I thought I meant to have this up earlier. So just to give a sense of what those timelines mean overall, if we're looking at HPV vaccines. So 2006 is when Health Canada first authorized our HPV vaccine. Most provinces and territories very, very soon afterwards started to implement those school-based programs for females between 2007 and 2009. It wasn't until 2013 to 2017, based on the different province or territory, when males started to be included in those programs. And then we now have a new recommendation coming up from NACI about reduction in the immunization schedule. So you can see those timelines can be quite variable by each province and territory in terms of how program and when a program might be implemented. Next slide, please. So I'm going to very briefly run through the NACI recommendations. I know Dr. Rand's going to cover them in much more detail, but just to cover the salient points. Number one, NACI continues to strongly recommend the HPV vaccine for everyone aged 9 to 26. That's been their recommendation previously, and it remains a strong recommendation based on new evidence. The major change is that they're now recommending individuals aged 9 to 20 to receive 1 dose of the HPV vaccine, and individuals aged 21 to 26 receive 2 doses of the vaccine. And that's different from the previous schedule, where it's 2 doses for individuals basically aged 9 to 15, and then 3 doses for anyone who is older than that. And that's the current program that most provinces and territories still have in place right now. They do say that there should be considerations at the individual basis for different healthcare providers to consider whether a specific patient should be getting a 2 or 3 dose schedule or 1 dose schedule just based on their particular individual medical condition. NACI is continuing, of course, at this point to recommend the non-covalent vaccine, as provides the greatest coverage over the multiple types of HPV that we have circulating. Next slide, please. The other thing that NACI is recommending is that individuals 27 older may receive a vaccine. So this slightly differs again than the strong recommendation to receive a vaccine from the previous recommendations. And this is essentially saying for high-risk populations who are over the age of 27, they may consider a vaccine, but it's a bit more on an individual level based on someone's personal risk factors. So what we see is that in most provinces and territories, this is implemented by a high-risk program with these sorts of things. So for example, in Ontario, there's a high-risk program for men who have sex with men who are older than the school age program to still receive HPV vaccine based on their individual risk factors. Next slide, please. Last thing I want to talk about very quickly is cervical cancer screening, because this is where we're seeing changes happening right now. And this ties directly into the outcomes we're looking at and how we're actually measuring the effectiveness of any HPV immunization program that we have. So cervical cancer screening recommended for people who have a cervix, aged 25 to 69 is the Ontario ones. I know it slightly differs based on province and territory, and are sexually active and don't currently have any symptoms of cervical cancer. And everybody in that population, regardless of whether they've received the HPV vaccine or not, should still be routinely screened for cervical cancer. So next slide, please. Basically, we now have the addition of HPV testing to what was previously a cytology program. So PAP was what we've done for many, many, many years. It detects abnormal cervical cell changes. These are primarily caused by HPV infection, but not solely necessarily caused by HPV. We now have the HPV testing available that's been looked at broadly globally. And this looks at infection with oncogenic strains of HPV in those cervical cells. It is more sensitive than cytology for detective cervical cancer, but is less specific. So again, that means differences in how the program's operating. And a negative test means that people are at lower risk of developing precancer or cancerous lesions, and then they would have a slightly different ongoing screening schedule based on a positive or negative HPV test. And to date, only Ontario, BC, and PEI are provinces that are using this, and Ontario is as of like literally 2 weeks ago, so it's really just starting. Next slide, please. And again, this is the summary of how it works. And again, you can see that based on different risks, based on what types of testing you're using, there's differences in recommendations of how often somebody should be getting screened. Next slide, please. So almost done. So basically, what are we looking at when we're monitoring an HPV program? If we're moving to a one-dose program, what are the types of things that we look at in overall immunization programs? So number one, particularly for any program change, we're looking at things like effectiveness, duration of protection. Are there changes in acceptance of vaccine with a one-dose program versus a two-dose program? And then we look at population level, any changes in the epidemiology we're seeing. And that's when, having things like HPV testing is really, really helpful. As part of our program evaluation, so whenever we have a public health program, we want to look at how is the program doing? Are we meeting the targets we have for the program? Are we covering everybody in the school-based program? How's the delivery going? What are the costs of the program? Those sorts of things. And then, of course, outcomes. And for HPV, cancer-related outcomes are number one. But again, with HPV testing, we do have a more proximal outcome we can start looking at now with HPV infection, and we know how that will eventually lead to longer-term cancer-related outcomes or non-cancer-related outcomes that are from HPV. So next slide, please. So just give an example of how this would happen in Ontario. And what are the data sources available? So for that program evaluation component, for that routine school program, we have data in our Panorama data system where health units record all the doses that they are administering in school-based programs. We, of course, have the costs of what it costs for health units to operate those programs in schools. And so we can see the change if we were to move to a one-dose program versus a two-dose program. Does that mean, health units are going to schools less often? So that reduces the cost of the program overall. So those are the kinds of things that we can look at. There is obviously the catch-up program still through healthcare providers where we have things like our OHIP billing data, or even just distribution data of product that's going out to providers. So we can follow up what is the coverage like based on what we're seeing in providers. And similarly, we can see those costs based on the billing as well. If we're looking more at the outcomes, there's a couple of groups we would primarily use in Ontario. The Institute for Clinical Evaluative Sciences, or ICES, they hold the majority of data holdings in Ontario, and they can do great link data. So looking both at the individual level for linkages or population level data. Public Health Ontario, of course, has all of our immunization data. And then places like Cancer Care Ontario, they, of course, have all of the outcomes data that are cancer-related. So those groups working together could do link data on either the individual level or at the population level to really give us a good summary of the outcomes of any current program that we have, and, of course, changes in any immunization program if we were to make a change. So next slide, that's everything for me to start things off. Thanks so much, and happy to turn over to, I think, back to Ian, I guess.
Thank you very much, Dr. Warshawski. Great start to our webinar today. And as Dr. Duran gets her slide set up, I just want to remind everyone that you can post a question using the Q&A module at any time. Because also, if you like a question that you think is really important, you can upvote it as well. So you don't have to wait to the end, but we will wait until the end of the presentations to address those questions and answers. So with that, I turn it over to you, Dr. Durant.
Well, thank you so much, Ian, and thanks so much to Daniel for such a great overview for HPV in Canada. And that's really what we're going to be talking about today. In the introduction, as Ian mentioned, I am somebody that focuses in colposcopy for the last 30 plus years. So colposcopy is actually treating and following people who have HPV-related diseases. But since about 2006, with the launch of HPV vaccines, my interest has turned from just secondary prevention of HPV-related diseases to include primary prevention through vaccination. What I'm going to talk about is sort of the next stage of the NACI recommendations and alternative dosing schedules, and look at ways how can we increase our provincial HPV vaccine coverage rates, especially in our school-based program, and talk to you a little bit about counseling approaches for HPV prevention. Well, globally, what is the picture of HPV-related diseases? Worldwide, HPV is reported to cause at least 5% of human cancers in men and women, including the cancers that you can see listed here. But remember, HPV also causes non-malignant disorders in addition, such as external genital warts, recurrent respiratory papillomatosis, especially in children. And remember that things like external genital warts far outnumber all of the HPV-related cancers combined. So the challenge is that not all countries are like Canada, where we do have screening for cervical cancer, and many of these other cancers don't have any methods for screening to detect before something becomes cancer. In high-resource countries, we've been plotting the declining rate of cervical cancer over the past several decades against the rising incidence of oropharyngeal cancer in males caused by HPV. And in many countries around the world, we've seen now that oropharyngeal cancers in males has overtaken the number of cervical cancers diagnosed every year in females. But something interesting has happened recently in Canada. When we look at the Canadian cancer statistics that were published in the fall of 2023, something was changing. Cervical cancer had been declining previously at about 2% per year since 1984. And for the first time, cervical cancer has now been seen to be increasing 4% per year. And this is important. This is the highest rate of cancers, rate of rise of all cancers in males or females. And remember, this cancer is preventable. And if you think that this rate of rise is due to COVID, you're wrong, because these are reported numbers from 2015 to 2019 before COVID started in 2020. So this increase in cervical cancer is not due to COVID. So I'd like to look at our Canadian landscape of HPV and vaccination. Where are we? We know that, as Daniel showed us, that we have suboptimal HPV vaccination rates in our provincial and territorial school-based programs. And we do still have low adult HPV vaccine uptake, about 12 to 15% of adults. We have a lack of integrated national registry or linkage with the provincial registries. They don't talk to each other. We've seen that we have increasing both cervical cancer and oropharyngeal cancer in Canada. Now, if we look at approvals to review what Daniel has told us, the 9-valent vaccine in Canada is approved for both males and females. First, it's approved by Health Canada, and that approval is for age 9 to 45, but then NACI goes a step beyond and has recommended HPV vaccination for those over the age of 9, regardless of gender, with no upper age limit. The indications or the reasons that this vaccine was approved by Health Canada is for prevention of cervical cancer and precancer, vulvar and vaginal cancer and precancer, anal cancer, oropharyngeal cancer caused by HPV, and anal genital warts. And then last summer, as Daniel mentioned, NACI came out with an update at the end of July 2024 that was a look back at alternative dosing schedules. And what did NACI tell us? Their recommendations now are for age 9 to 20 to receive 1 dose of HPV vaccine, and for those age 21 and older, 2 doses at least 6 months apart. Now, one thing to mention, currently these alternate dosing schedules are off-label recommendations in Canada. These are not approved by the manufacturer. For those who are immunocompromised or those living with HIV, NACI still recommends 3 doses given over 6 months. All provincial programs and territorial programs in Canada remain at 2 doses at 0 and 6 months, except Quebec, which moved to a 1-dose schedule this past fall. Now, if we look at NACI's recommendations, we're going to see how did they come to the conclusion of alternative dosing. The NACI statement was based on 3 studies. One study was a randomized controlled trial called KENJI from Africa that went for 36 months or 3 years, 2,200 in that randomized controlled trial, females only. We have 2 observational studies. 1 dose is not randomized. Females only were studied. 1 was done in Costa Rica and 1 was done in India. It's important that we know there are no male studies looking at alternative dosing to date. And this is really important for what Cheryl's going to talk about next, which is oral HPV infection and the disease that it causes. We also don't know beyond 3 years the long-term duration of protection. Now, we all hope that alternative dosing will be shown scientifically to be valid. We have a large 1-dose randomized controlled trial, which is due to be reported in the next 12 months or so, called ESCUDO. This is going to be more than 20,000 individuals, well-designed randomized controlled trial, and this trial will hopefully help us answer this question better. But at this point in time, we are relying on a small 1 randomized controlled trial on females only. There are countries around the world who have turned to alternative dosing, such as Australia and the United Kingdom. So I want to point out some of the reasons that they went to alternative 1 dose in their school-based programs. These countries have very high vaccination coverage rates in their national programs, more than 90%. these countries have decreasing disease rates, decreasing external genital warts, cervical cancer, and precancer. And these countries have robust national registries for surveillance, vaccination registries, screening registries, and disease surveillance registries. Even countries like Sweden, who have all of these things in place, there are some that, like Sweden, that have chosen to stay with the two-dose program until the data is more robust. Now, cautions for Canada. Unlike Australia and the United Kingdom, our provincial and territorial vaccine coverage rates generally are still low. For example, if we look at Ontario's grade 7 program last year, 52% were vaccinated in our grade 7 program. British Columbia, 58%. Ontario, for example, is lower than it was pre-COVID. When we're lower than 70% vaccination coverage rate, we have no herd protection for the unvaccinated, meaning those who are not vaccinated are not protected by those who are vaccinated. We know in Canada that our cervical cancer rates are increasing, not decreasing, and we don't have any integrated national registries for surveillance. This is how we will see a red flag if alternative dosing is to cause an increase in disease rates. And because we don't have a registry for vaccination, it's going to be difficult for us to recall for booster dosing if this becomes necessary. Remember, all of these alternative dosing are still off-label in Canada. So this is a matter of disclosure to parents and adult patients that if we're talking about alternative dosing, it is off-label. If provinces and territories move to one dose, remember, as Daniel mentioned, reported vaccination coverage rates will automatically increase because someone who's only had one dose will now be considered completely vaccinated, even if no additional children are vaccinated. So rather than switching right now to alternative dosing, including one dose, we should really be focusing on how can we increase vaccine coverage rates in Canada. The public HPV programs really need to be a team approach, not just a public health task. We all need to participate as healthcare providers in this task. And we really want to think about what do parents and adolescents and providers and educators want to know. Parents declining HPV vaccine in our school-based program are not doing so based on the number of doses. They are doing so based on their hesitancy about the vaccine, about misinformation, and sometimes even disinformation, and vaccine fatigue for sure, since the onset of all of the vaccinations we've had to undergo over the past few years. How can we explain in certain public health regions low vaccine coverage rates versus high vaccine coverage rates? We really need to look at how can we explain some of the contrasts. Certainly there are demographic differences, cultural and religious differences. There are matters of inequity and special populations who we don't reach. But one thing we all forget is, what do parents and patients consider the most important reason that they will vaccinate themselves or their children? Our recommendation. We forget that our recommendation is often the deciding force in a parent or a patient making this decision. Success is not always related to our resource setting. We are a high-income country, but there are many low-income countries that have been successful, more successful than we have been in HPV vaccination. And I want to point you to the example of Rwanda. In 2011, Rwanda was the first African country to launch a national immunization program, and this is in a low-income setting. They achieved more than 95% vaccine coverage rate in the first year of their program. They have a culture of local accountability. They engage stakeholders actively, and they have maintained more than 90% vaccine coverage rate over the past decade. And what's interesting is it also resulted in an increased cervical screening rate with the success of their HPV vaccination program. So let's think about some of the recommendation approaches to vaccine, including HPV. Currently, our approach really is a participatory approach, like an opt-in. We are asking your wish to participate. For example, in Ontario, we require 3 separate signatures for 3 different vaccines given in the same grade. And it's really, we're asking, would you like your child to have the HPV vaccine? Alternative is a presumptive announcement approach. sort of like an opt-out, where we are going to assume your participation in the program. So here's an example. Taylor is going into grade 7. We vaccinate all our children against disease because we care. Next fall, students will be receiving 3 vaccinations for meningitis, hepatitis B, and HPV vaccination. HPV vaccination protects against 6 types of cancer. So what did you hear me say? You heard me say this is a vaccine that can prevent cancer. You heard this cancer can affect everyone, including males. And the best results are when we vaccinate as early as possible. What I didn't say, this is a vaccine that protects against sexually transmitted diseases, and that we want to vaccinate before the onset of sexual activity. So really focusing on our messaging is important. Why should you and your loved ones get vaccinated for HPV? This is a vaccine that protects you against cancer. These cancers are preventable, and we don't want to lose you to this disease. We need to really keep our messaging simple. There's 3 things the patient and the parent wants to know. They want to know, number 1, does it work? Yes, it does. Number 2, is it safe? Yes, it is. But we forget, most importantly, number 3, do you recommend it? Yes, I do. Let's get you vaccinated. We can start today. Just like COVID vaccines, patients are really looking to us that HPV vaccine is a trusted vaccine. I want to say a few words now about adult HPV vaccination to expand a little bit on what Daniel was presenting. The launch of primary HPV testing, which will come into play across the country but is currently in 3 regions, is really an opportunity. We are automatically going to have increased awareness of HPV because we have to talk about it as we are doing this test. And we need to learn to link our discussions for primary HPV testing for cervical screening, link them with prevention through HPV vaccination for both patients and their partners. So these counseling moments can be even before we book the test, at the time of performing the HPV screening test, and when we discuss HPV test results. So for example, what could I say? We can use that test result to discuss vaccination. So we can say, Marie, your test came back negative for high-risk types of HPV. This is great news. We can vaccinate you against HPV to reduce the chance of you developing an abnormal test or cancer in the future. Let's vaccinate you today. Or alternatively, Marie, your test came back positive for high-risk HPV. Now we're going to need to do further testing, and we may need to refer you to a specialist. We also know that vaccinating you against HPV, even after you've had a positive test, can help reduce the chance of future episodes of abnormal cells and disease. Let's get you started. We can vaccinate you today. But we've talked about cervical screening. We can't forget to vaccinate the males because all male HPV-related diseases are rising, and particularly men having sex with men are at higher risk. We shouldn't assume when we're seeing a young adult, let's say in age 20s, that they've already been vaccinated, because many will not have been vaccinated in our school-based program with our low vaccine coverage rates. And also, when we are counseling adults about the value of HPV vaccination, if they believe in the value of this vaccine, this person who's an adult is now a parent or may become a parent in the future, and they are more likely to consent their children for HPV vaccination in our school-based program. So we really get a dual benefit of increasing the vaccination of children, which is the best time in our school-based program, but also for vaccinating adults. So I challenge you, this is really a call to action. We need to be advocates. We need to educate ourselves on HPV and vaccination. And we need to speak to everyone, whether they are patients, friends, or family, about the importance of prevention. And truly, we should be setting an example. We should be getting vaccinated ourselves to be a leader in preventive health care. Personally, policy should always follow the science, not the other way around. So I'm going to stop here and hand back to you. Thanks, Ian.
Thank you so much, Dr. Durand. Another great dive into this issue. And so just remind people, we've got a few questions posted already. Keep those questions coming in as I turn the floor over to Dr. Cable. Dr. Cable, whenever you're ready. Unmute yourself, please.
That's not the usual request. So we're going to talk from a dental perspective. I am so thrilled with such a powerful team with Daniel and Nancy in providing the background, the understanding from the physician's perspective. But I would like to show you from the dental side. So we're going to talk about HPV-related head and neck cancers, and then focus on the human impact of the high-risk HPV types. So as we know, there are low-risk types of HPV, and then there are high-risk types of HPV. In my world, the ones that we're really looking at are head and neck cancers. So why is a dentist talking to us about this? Well, I want to tell you a story. If I can tell you a narrative of a patient in what they go through, including from diagnosis to the surgical oncology interventions, but all the way to the end, then we have an anchor and understanding that maybe you weren't aware of before. So how does head and neck cancer in Canada present? Well, all of these are squamous cell carcinomas, P16 positive, so of the high risk type, the P16, the HPV type, is what's associated with HPV. But this isn't a pathology lecture. So if you see something wrong that lasts more than 2 weeks, we know when in doubt, get it checked out. So how do patients present? Well, usually with men, it'll be while they're shaving and they'll find a lump or bump in the neck. That's a very common presentation, something that doesn't go away. When you go to the dental office during examination, they may find something. So the dentist, dental hygienist, and possibly a denturist. Well, and that's why we're really trying to educate. So something that you may not even be aware of. Sustained voice changes that last more than 2 weeks. There is no direct cause for this. And also if something just feels off. So that is the presentation of head and neck cancer, oral cancer in Canada. When we look at the number of cases, we also have to talk about, Nancy was fantastic in the estimated number of cases from our last big Canadian Cancer Statistics document in 2016 in genital warts, but recognize they're oral warts. And so dentists, pathologists, surgeons on a regular basis are removing what are beautifully described as either being cauliflower or bananas, so little lesions inside the mouth. And they are commonly removed with excisional biopsies in terms of either laser and or in terms of cutting them out. Oral pharyngeal cancer cases are next most common now than cervical cancer. Unfortunately, as Nancy stated, that the cervical cancer cases are rising, and as are the oral pharyngeal cancer cases. Now, in Canada, the average number of new cases of head and neck cancer is projected to rise. So from 2003 to 2007, up to 2028, 2032, by 58.9%. In Alberta, the same time, same rate is rising at 76.1%. So we'll commonly describe this as a tsunami of head and neck cancer cases coming through the healthcare system. This is all across Canada. So from 2000 on, when we had this research project, which was published in 2017, right across Canada, the proportion of HPV positive patients with head and neck was increasing from 47.3% to 73.7% in 2012. So there is a steady rise in the proportion of oral pharyngeal cancer cases. The burden of the disease is mostly carried by males. So it is about 5 times more common in males than in females in the United States, similar in Canada. Now, what's interesting is that oral pharyngeal cancer cases typically can present 20 to 45 years after you've had your HPV infection, the primary infection, with a median age at onset of 63 years. So when I went to dental school decades ago, we were taught patients with squamous cell carcinoma would present as usually an older male, increased alcohol content intake, smoker, out in the sun, Now the presentation is younger, so it's shifting down. I'm looking at males between the ages of 40, 50, 60. They're highly educated. They could be my accountant, they could be my lawyer, they could be a fellow dentist, they could be my physician, they could be any of us. And so when I talk to patients about the disease, when I talk to them about the cancer-causing virus, is it's almost having a conversation like a cold sore. So once you've been exposed and if you've not had the vaccine, the virus is in your body. And if the cancer can present on average about 30 years afterwards, it helps with the conversation when they start looking around going, well, I haven't been with anybody else, and we can diffuse a situation there. And we can talk about some of those things later in terms of counseling patients. So unlike cervical cancer, at this time, there is no adequate or cost-effective screening test. There's no spit test yet. There's no swab that doesn't exist yet, but we're pretty darn close, and that's our goal. So what's our role in terms of all this? Well, we have to not just treat, but we have to prevent. So we're on a search and destroy mission, and we're looking at preventing these cases. We're looking at getting ahead of the tsunami. We're looking at how to be proactive. The anatomical locations of select head and neck cancer cases, really, when we're looking at HPV positive, they're further back in the throat. So think about the times when you look at your patient, and usually you're in with a tongue depressor and you're looking at tonsil form. That's great, but we still have to pull the tongue out. We still have with an opened up 2x2 gauze, looking underneath, manual palpation, looking in the oropharynx, looking for asymmetries, erythema, edema, anything that's not moving away. And it's much harder to look in the back than it is in the front, which is where the team comes in. So when the patient is identified as something's wrong, we'll usually send them to a pathologist. So you can send them to an oral pathologist, oral medicine, oral surgeon, ENT surgeon, someone who's going to do a biopsy. And then once we have that, we start going into a diagnostic pathway. So we'll involve radiology, multiple diagnostic tools, but this is where the multidisciplinary treatment planning sessions come in. And this is what leads to a better outcome for the patient. And it also includes the patient as part of that treatment planning and understanding of what's happening and why. The treatment and the long-term care of these patients can be quite substantial. So fortunately, P16 positive squamous cell carcinoma responds very well to radiation if you catch it early. So we want to be on top of these things, but radiation we know will destroy salivary glands. It causes local area effects, will cause significant dental effects, and medical oncology. The surgery involved in head and neck reconstruction. This is when we're in the operating room, on average, about 20 hours. And then there's multiple teams involved depending on the extent of the surgery. The ICU is not your regular ICU, it's a full pulmonary ICU. Then the patient is sent for home care, psychology, and it is a long haul. It is literally in your face. The long-term rehabilitation involves a multidisciplinary team. We will have lots of swallowing issues, so we work with SLPs, trying to make sure that the patients post-radiation surgery are not going to be regular in the hospital with pneumonia, and that we're trying to make sure that the food, liquid go down the right way. They can speak and be articulate. We're working with dietitians, dental teams, psychology, psychiatry. There is long-term disability, isolation of the patients, and continued costs for long-term rehab. So the image on the bottom left, you're wondering, why does the patient have hair in the floor of their mouth? Well, the little tip of the tongue that's sticking out there is all that's remaining of the tongue, but it is graft from the patient's forearm to replace what is missing with the surgery, so trying to cover things up. So you can do laser hair removal, but time is of the essence in getting the graft in there. The middle image is a picture of a patient's roof of the mouth, and that's how the surgeon had tried to close the hole in the mouth, but because of radiation, we have vasoconstriction. So the tissue does not respond well. So I can make a prosthetic that goes on top of the roof of the mouth that allows the patient to eat and drink and be part of life. And then we can establish where we are, if we need additional grafts, if we need iliac crest, if we need fibula, what else is going on. The image on the bottom right shows just the impact of, and this isn't active cavity, this is actually demineralization of the teeth long-term, post-radiation, the severe xerostomia impacting the patients. I would like to show you how fast this disease can act. So this is the difference a year makes. This is a radiograph, a pantogram, so a oral pantogram, and panoramic radiograph that was sent to me by a surgeon saying, yeah, patient had radiation, all these teeth need to come out. And so when I look at this image, I'm like, doesn't look bad. Actually, I just see an angle of the mandible, history of heavy clenching, lots of restorative, some root canals, but there's nothing indicating this patient needs their teeth removed. So they check and send me this image. I'm like, okay, that's right. So what we see here, those little white clips in the patient's neck, is with a post surgical situation with bilateral neck dissection. When the surgeon's going through and hits a blood vessel, these are clips to prevent the patient from bleeding out. The loop in the patient's bottom right, which would be your left, is the submandibular gland transfer, and it's marking the salivary gland, moving it anterior and out of the way, ideally of radiation, so that the dosimetrists, when they're planning the radiation loops, will try to protect the salivary gland and try to protect the saliva flow. In this situation, we see bombed out teeth, which is the term for just huge carious lesions, periapical abscesses, infection in this patient's mouth. So there's an indication that all of these teeth need to be removed. Now, does this state that the patient is just not taking care of themselves? Well, frankly, this patient's trying to stay alive. And this is not unexpected. But I want you to look on this image on the tooth in the top left. Look at the shape of the amalgam. So we know this is metal, we know. And this is a good call for keeping amalgam in because it helps us identify root canal. But I want you to look at the slide before, slide after. This is the exact same patient. So this is 1 year. The previous panoramic was taken right before the patient went in for surgery. And so this is how fast this disease can progress. This is an example of one of my patients with facial reconstruction. When we look at the top image, you'll see the plating where the surgeons opened up the mandible and had access to florid tongue, removed most of the tongue. So in the second row of images, middle image, you will see the bright pink on the left and the more whitish on the right. Excuse me. That's a forearm graft. So the only amount of tongue that's left is on the patient's right. Teeth were deemed non-restorable, so extracted, placement of dental implants. Because of the graft not moving, I had to make a prosthetic that snaps on, snaps off, and did not affect the tongue because now we have a keratinized tissue in place of where the mucous membranes are. And so this is the best case scenario. Patient's able to function, able to eat, patient is able to participate in society. This is an example of the kind of case I have to do if the patient is severely xerostomach and can't have any dentures or any tissue-borne prosthetics. So I will make a titanium milled bar with attachments on top. Image on the top right shows you the bar on the top and the mated component, the mated prosthetic that goes on top of that. And then the lower prosthetic is screwed in place. Image on the bottom right shows how the patient has to clean with brushes underneath. There will be food trapment, but it allows the patient to have a functional prosthetic and understanding I intervene for comfort, function, aesthetics, and preserving their anatomy. So it comes down to quality of life. Sometimes the multidisciplinary team has to approach and how do we plan the dental implants if there is no bone or if the patient is not a good candidate for a fibula graft or an iliac crest graft. And then I have to plan where I want the teeth in the meantime to go. So it's a multidisciplinary, can be many countries involved in this. And then we have the digital technology is such a huge advantage. But as you know, and as you understand, none of this comes cheaply. So when we look at patients and the long-term consequences, yes, with radiation, we have short-term, long-term effects. Chemotherapy, the same thing. These affect patients for life. And then the surgery, which is to eliminate the disease and to stabilize the patient's mouth. If you've ever been part of the situation where you're ringing the bell and the patient's end of treatment is a very joyous occasion. It is not the end of the patient's journey. In fact, the patient will end up with psychosocial impacts. So we have facial disfigurement, difficulty swallowing, choking, loss of taste or smell, which can be permanent, difficulty speaking, especially if you're missing your tongue, you're missing part of your face. The suicide rates of these patients are twice as high as any other cancer patient population. And it is very delicate in terms of what we're taught, what we're not taught as part of our programs, and just understanding which teams follow the patients to end of life. So I am part of the main program. I do support patients in the decisions that are right for them. But we have to understand this is very, very significant. And this, for oropharyngeal cancer being caused by P16, this is a preventable cancer. The socioeconomic burden is not just the healthcare costs. There are huge costs to that, all the way from diagnosis through all of these modalities. But the dental cost right now in Alberta, our dental costs can be anywhere between $40,000 to $80,000 for rehabilitation. Every province and territory has a different mode or opportunity for patients to have this treatment completed. We have one fund in Alberta where the patients can have rehabilitation done one time, no remakes, no repairs, and so that for the rest of their lives, they are personally responsible. A lot of these patients do not go back to work, end up on long-term disability. And it is a huge, huge impact because if it were not for the medical situation, not due to the radiation, due to the surgery, they would not end up in there. So the separation of dental healthcare from healthcare in Canada is a very, very strong point of conversation when the disease happens to you. To the rest of us, we have dental insurance and we go through the mode. But this is a very special, vulnerable population that we need to look at, and we need to address the quality of life. So what can I do today? What can we do? Well, when you take your medical history, take a vaccine history, you're going to explain why this is being asked and why they're at risk. So we're going to explain that if you've not had the vaccine, you're at risk for 6 different kinds of cancer, and based on their specific presentation, why this is important. The importance of completing a comprehensive head and neck examination. So when I do a head and neck exam, or a hygienist does it, or my nurse practitioner does this for me, it's value added. And we're saying, okay, I'm doing this exam because, just taking care of you, and we're making sure that there's nothing else going on. But there's a responsibility to the clinician, not only as a competency-based trained education and expectation in what you're doing in terms of national education, but there's a responsibility if you are billing for a head and neck examination to insurance. And if you are not doing that, or if someone is not doing it on you as the patient, then you need to ask the question, why is that corner being cut? And the patient has a responsibility of being told that if you choose to smoke, if you choose to continue to drink, if you choose to have high risk activities, if you choose not to have the vaccine, then you're going to keep an eye on things, because I'm not here, I'm not your mama. I need you to make sure that if there's anything that's red, white, there's a lesion, if you get a sustained voice change, anything that happens for longer than 2 weeks, you call the office and we're going to document that. There are ongoing conversations within dental environments that I'm aware of, or clinicians who have been following lesions over time, documenting, taking photographs, measuring. If it converts to cancer, we have to take into consideration how litigious some of our patient populations can be. So documentation and providing opportunities for patients to make the decisions that are right for them is very, very important from a medical legal perspective. Number three, providing educational material. So even if you do not robustly support vaccination in any manner, or you personally do not feel that this is something for you, having the education material, including brochures, website information, office videos available, allows the patient to make the decision that is right for them. We need to close any open circuits. We either pause, pitch, or pursue an open opportunity, which is part of education. So once you educate the patient, you put it in the recall to follow up on that. If you can provide the vaccine, then provide the vaccine today. I know that Nancy's very, very good on that, in trying to get patients to understand, you have to take care of yourself. You have to act now, and we need to execute and make this happen. If that's not going to happen, or you're not a vaccinator, then you're going to provide a prescription and refer the patient to a vaccine provider directly. So establish these relationships. In dentistry, we have a pharmacy vaccine, a pharmacy dentistry corridor, and you continue these relationships. We have patients who are needle phobic. And so what we can do is provide a sedation environment where a pharmacist will come over and provide a whole bundle of vaccines all at one time. And that's how we're finding opportunities in terms of not necessarily changing scope of practice, but how we can support each other. So we continue the positive relationship with our patient, and we let them know we are supporting them and we're looking out for them, and we're making sure that their health is priority and that they are at the center of care. As Nancy said, as long as we provide the same language, the same message, we have the same goal and intention. So HPV, we know, is a leading cause of preventable cancers. We know the HPV vaccine is safe and it is highly effective. A missed vaccination is a missed cancer prevention opportunity. HPV affects everybody. Patients trust you, and you need to understand how important that relationship is. Healthcare workers, you need to protect yourself, protect your patients, and focus on protecting the public health as a whole. We need to actively think about how to protect our fragile healthcare system. If you are prepared to see an increase in the number of oncology patients, and you're prepared to see a number of patients coming in with preventable disease, then your healthcare system is very different than our healthcare system, where right now, several of the hospitals in Edmonton today are over 100% capacity. In Canada, we can eliminate HPV cancers, but only with higher vaccination and screening rates. So what if? What if I told you that I could give you a prescription for medicine today that would prevent you from getting cancer? Would you be interested? And 100% of my patients are interested, and it opens the conversation. So what if? What if we could do this together? Thank you.
Thank you so much, Dr. Cable. So much incredible information from all of our panelists this afternoon. I'm going to jump into the questions, and I'll start with you, Dr. Cable, because I thought it was kind of an interesting one, and you can perhaps fill in my blanks around scope of practice. But Julie asked the question, dentists see school-age children a couple times a year, or at least those who can access care. Do dentists have, within their scope of practice, the ability to ask questions about, have you had your HPV vaccine? Because it could be a great opportunity to get that message through, oftentimes because the parents are there as well.
Absolutely, yes. Medical history is medical history. You don't pick and choose. You will get patients who are quite grumpy and says, what does that have to do with my mouth? What does that have to do with me getting my teeth cleaned or getting x-rays today? And that starts the conversation. So yes, a big opportunity in cross communication and supporting this is pediatric dentists, family dentists, orthodontists. So think about, there's an expectation where kids will get braces now. It's more the norm than not. And so by having the same message, the same communication, the same brochures available, because when you're sitting in a dental chair, you're kind of captive. And it's a very almost intimate environment when you're seeing your family physician, unfortunately, or your nurse practitioner or your healthcare primary healthcare provider. You have a limited amount of time to talk about your top three things. When you're getting your teeth cleaned, it's almost an hour. And so this is a really large group we're working with in establishing safe conversations. And I know Nancy has talked about this previously, is how do you have these conversations about, um, when you've got a young clinician who's not used to talking about an STI, and opening that door. And so that's where we've learned so much from each other, and trying to cross-pollinate and just support and support and support from every opportunity.
Excellent. Thank you so much. And I'll remind the dentist and dental hygienist to take the tools out of the mouth long enough for the patient to actually answer the question, because it doesn't really cut it. So great. Looking at some of the questions we have, there's questions about a question about how we can effectively track vaccine uptake in Indigenous populations. What we're doing to improve this data set across the country. I think part of that we've discussed before around we don't have interoperable registries in this country for Indigenous or non-Indigenous Canadians. But do any of the panelists want to respond to that question?
I can chime in on that one.
Perfect.
I mean, never mind interoperable registries. Not every province and territory has a functional registry individually. So yes, we're certainly limited. So Ontario, for example, other than like HPV is one of the best doses that we have covered because predominantly given by health units in schools. Doses that aren't given in schools are not tracked, more or less, unless someone's voluntarily submitting that. In other provinces, it's different. Some of them, Alberta has a much more comprehensive registry where all doses, even private pay doses for some vaccines, are included in the registry. So getting up to speed across the country is something that's kind of ongoing work. I mean, to be fair, has been ongoing for decades, but it's still ongoing, and there's been a lot of recent federal move to get this much more in line, particularly for Indigenous populations. With everything I said about our non-Indigenous populations, unfortunately, we only see more poor data quality for Indigenous populations, depending on both whether they're living on reserve or in urban settings, and or even identifying as Indigenous within the data sets that we have. So it's very, very limited generally.
Excellent. Thank you. And I see that you were starting to type a response about the next question for the general population, the value of getting the 9-valent vaccine if they had previously gotten the older quadrivalent vaccine. So maybe you'd like to finish that.
Sure, yeah. I can start, Nancy can probably jump in too. So there is certainly value in getting the 9-valent vaccines. We recently had a discussion about, the new pneumococcal vaccines where we now have 20 and 21 compared to 13. One of those is a bigger number. It covers more things. Of course, it's better ideally to have those ones if we can. There's diminishing returns, of course, as you're adding them on. And if we're looking at a public health program to operate it, that's a different question at the individual level. But individually, absolutely, I would recommend everybody get the 9-valent vaccine if they have it available. In Ontario specifically, if you've had one of the previous HPV vaccines, you wouldn't be eligible under OHIP to receive the new non-valent vaccine, and likely would have already aged out of the school system as well, given when we last used the other ones.
Yeah, so I'll jump in on that. And Daniel, yeah, he's right. This is not something that OHIP or your provincial program would ever cover if you'd received something in your school-based program. So what is the added value of 9-valent over one of the first two vaccines, bivalent or quadrivalent? So the first two vaccines for cancer protected against type 16 and 18 in both of them, and they protect us against 70% of invasive cancers. When we increase that to 9-valent, we now cover 90% of invasive cancers. So the added benefit is the strains that cause 20% more of invasive cancers. Depends on where you live, whether those strains are important or not, too. So if you're in a place where only 16 and 18 types are predominant, then the added benefit may, in fact, be less. But I can tell you, practicing in Ontario, where we've, in the colposcopy setting, have done HPV testing for years, we have a lot of other high-risk types in the area in which we live. And so we do discuss the added value of 9-valent vaccine over quadrivalent, or if they got an original bivalent vaccine to each and every person. But yes, this is something that is a private pay. So the person is going to pay either themselves or through their insurance plan if they have an insurance that covers vaccinations. And what he was alluding to is there's two ways of thinking about that added benefit. On a population basis, this is not something that we would be covering as a public health goal where it would be funded 9-valent if you'd received previous quadrivalent. But this is on an individual basis, the person sitting in front of you, where you are discussing the benefit to them specifically of this vaccination. And age, we know, doesn't seem to matter, that these vaccines do work and have efficacy data that supports their use in those over the age of 26 as well as under the age of 26. So we know there's risk of new infections in older people. And those risks are increasing as prevalence of HPV is increasing. And so those are the discussions that we would have in a one-to-one basis. Daniel would not have this discussion on like a provincial basis of coverage of these broader populations.
Excellent. And while you're on that topic, Peyton just added a question for clients, patients who already have been told they have HPV. How beneficial is receiving the Gardasil 9 or the 9-valent?
So that's a great question because we'll often think, well, if I have HPV now or I've had it in the past, then there's probably no benefit because I've already been exposed. And in fact, the data does not show that. So for people who have had past or current exposure, vaccinating them is of benefit and seems to reduce future episodes of HPV positive related diseases. So in fact, it's the reverse. We target and we want those people to get vaccinated because we can protect them against the types they've not yet been exposed to. And we know even for the types they have been exposed to, it reduces the chance of future abnormal tests and disease. So in fact, we do, and we don't exclude you based on gender, based on age, or based on your past history or current history of HPV.
Excellent. Thank you, Nancy. Daniel, I'm not sure the Mariev's question. Can you speak to coverage for the vaccine of adults that have not received the vaccine as part of the grade 7 to 12 routine vaccine program in Ontario?
Sure, yeah, I can be quick. We had a short-term catch-up after COVID because of the missed doses for a few individuals who graduated, but that has since ended. So we're back to just the strict coverage in there. There is a high-risk program in Ontario for men who have sex with men up to age 26 to be covered for the HPV vaccine, so they can still receive it. That's the limit of the high-risk program at this time. So basically, right now in Ontario, once you have aged out of grade 12, you're no longer eligible, even if you haven't even completed the series, but started it within the school-based setting.
And a call to action for those who are policymakers like Daniel participates in. MSMs are certainly a high-risk group. Another high-risk group, which has coverage in 7 out of the 13 regions, is those living with HIV. Ontario is not one of them. So if you happen to be a person living with HIV who is an MSM, you have coverage because you're an MSM. But if you're a woman living with HIV, you're not covered for HPV vaccination. This is a very high-risk group of individuals, and certain provinces and territories have chosen to cover vaccine, and this is one that many of us wish could be included in that additional high-risk program.
Excellent, thanks. And again, Daniel, do you have any insight into vaccination programs in correctional settings, obviously specifically in Ontario?
I can say that our programs are always under review, particularly HPV, given the recent NACI recommendations. It's certainly under review, both the change in the dosing schedule based on NACI recommendations, but also the evaluation of the high-risk program. To date, what is in the high-risk schedule is MSM, as I mentioned, and we'll see what happens.
Excellent, thanks. And then we've got a lot more questions that were sent in to us before the webinar, so we'll get to them in a moment. But I'm not sure if any of our panelists can speak to Adrian's question about any changes in the recommendations about male vaccination in light of the increased cancer rates, because that would kind of be a NACI kind of question. So let's hope so.
But age is not any different for males or females. And so it depends if you're talking about coverage of programs provincially. It currently is for all boys and girls in all provinces and territories. And that is the best place for us to get males vaccinated is as early as possible in our school-based programs. And we are very lucky in Canada. When I speak globally, they're amazed that Canada in every province and territory has funded HPV vaccine for all children across the country. But we need to utilize that better.
Absolutely. Absolutely. Dr. Kimball.
Unfortunately, unfortunately, we didn't start vaccinating males at the same time or at the same rate or awareness that we did with females. And so now it's not just the catch up of who we've missed. Now it's being aware of the disease, transference of the disease. But now we also have to be aware of where our patients are coming from globally. And if the vaccine coverage globally is as abysmal as it is, when we're looking at 4% of males globally have received full doses, then they're carrying viruses with them, and behaviors and changing acceptance of behaviors is there. A lot of people um, do not think that HPV is a male disease. It is an us disease, and we have just not been kind in understanding or as emphatic as what we need to be. So it's not that we need catch-up doses. I think we need a whole, I hate to use the phrase, paradigm shift in our understanding of vulnerable populations. In fact, anybody who was not offered the vaccine in a school program is vulnerable. And we have to be aware that every point of opportunity that we can help them, that we can educate them so they can make the decision that's right for them, is what we need to do. So it's not, borders have no meaning anymore. And communication is rampant. Conversations coming up from the States right now, thanks to different political platforms and people saying, well, it's no good. Well, let me tell you why it's good as a clinician. Let me tell you why I vaccinated myself and my partner. Let me tell you why I vaccinated my 4 children. And if my son, who's in grade 6 this year, did not receive the second dose, I was going to take him to the pharmacy and get the second dose myself and pay for that out of pocket. So the conversation needs to be much more robust in terms of awareness of who we're missing. We have points of contact, but we have a lot of opportunity here.
Excellent, Cheryl. And certainly, I have the recollection of how the entire HPV program was originally launched in Canada. It was rushed. No money was put into communications. It was poorly thought out and was intended to be a political play to get a female vote, and it backfired completely. But the most important part was there wasn't enough money in communications. It wasn't. It was rushed and pushed out way too quickly. So I'm gonna transition to some of the questions about the single dose schedule, and I think the one that perhaps I'd love to hear from all of you is the question: what ethical concerns arise regarding informed consent for a single dose HPV vaccine? So I'll open it up to anybody who'd like to answer that one. Or not. No.
I just
Okay.
think you need to. I think it's hard in the school-based program because of the way that consents have to be taken. It's a challenge in a school-based program. So I think that's something that all of us can participate in. And I think if we could, it's not always easy, but if we could do some of that counseling before the fall when the school-based program happens, if we could discuss, this is something that is going to be happening this fall, and we discuss this in the spring, if we could send home more information. And there are lots of different ways that different countries have taken to approach that question. I think it would really help improve our vaccine coverage rates. But I think that is really something is one of the areas we can all of us work on. It's not just a matter of the public health unit having to do all of that work themselves. I think we as providers can participate. I would love if educators could participate in that. In many countries, that is how it's done. The teacher or the school gets involved, not just the public health unit, in providing information ahead of time. Do you have questions? Do you have concerns? And providing avenues to help answer and hear those concerns ahead of time before the fall when we're sort of under the crunch to get those consent forms back.
Excellent. Thanks, Nancy. I want to follow up, and this is a naive question from a non-practitioner, and I'm pointing it to you, Cheryl. Should we be talking for dentists, like a revision of scope of practice for them to become vaccinators?
Oh, dentists in Alberta are already vaccinators. This has been
Okay.
part of our scope of practice for a very long time. When I talk about, combined opportunities, the very first person who did a vaccine in a dental office was actually an oral surgeon who was sedating a patient for another procedure. And while they were there, underneath it was like boom, 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 catch up program, got the HPV vaccine in place. When we talk about changing scopes of practice nationally, um, everything's changing. I get all my vaccines through my pharmacist. When we talk about changing scopes of practice in dentistry, education has always been there. If individuals choose not to vaccinate, it's a very strict system where you have to be registered with the provincial government. You have to have every dose monitored. And everything has to go back into the registry. Those are important guidelines. So we have to build the road before we expect the traffic. And that's where nationally we have billing codes in our fee guide as dentists for vaccine consultation, script writing, and provision, but not all provinces choose to include those fee codes within their fee guides. And that's where the conversation also has to come at the insurance level. So changing scopes of practices, that's the one constant we have in life. It's there within. So we should always be responding. We should always be changing, looking at opportunity, how to address the problem. Uh, should everyone be a vaccinator? No. Should everybody, be educating their patients? Absolutely. So this week, I sent a slide deck out to every single dental association across Canada with vetted slides on HPV, head and neck cancer, talking points so that we have the common language. And so that's part of a leadership role in terms of how do we combine ourselves nationally and address what's there so we're not getting little bits here, here, here. And that's where public health comes in.
Yeah,
Excellent.
if I can add quickly, then I'm going to apologize. I have to jump off a bit early to get to my daughter's birthday at school. So dentists in Ontario, dentists administered COVID vaccines if they wanted to during COVID, right? So it's less about the regulatory pathways enabling dentists to administer. Dentists inject things with needles all the time. This is not like a skill that we think dentists don't have. It's about, well, how does that fit into the system at a whole, as Dr. Keeble was mentioning. So for any publicly funded vaccine in Ontario, your public health unit has to come to your location of practice, inspect your fridge, make sure your cold chain is operating appropriately. Like this is a whole system that's in place to make sure that that ties into a publicly funded vaccine that's being administered, which is separate and aside from what are people allowed to do, right? So would it make sense to have dentists administering HPV vaccine as part of our school-based programs? Probably not. They're not going to schools. Does it make sense that they could administer catch up to individual patients? Maybe, but if we're talking about a population level, like how many people are going to get their catch up with their dentist as opposed to at a public health catch up clinic or with their primary care physician or nurse practitioner, right? If we're, this is a diminishing returns. Again, I mentioned before about like when we're expanding things, at some point we have to see, well, are the costs of operating a program that way worth the outcomes that we're going to get by a potential expansion? So, but my dad's a dentist and he's like, I don't want to give vaccines to people. So I'm just basing on that.
So when patients schedule appointments, I guarantee you I'm more likely to schedule my kids in to see their hygienist on a twice a year basis to go in and see for preventive, and then into the physician as needed based on the needs. So that's a different perspective and access. So why are more patients going to pharmacists for vaccines in Alberta? Is because pharmacists were the ones that patients went to through COVID. It became easy. My physician disappeared. And so we have changing scopes of practices, which are really important in responding to changing needs. Um, every province and territory is different, every clinician's different, but the focus needs to remain on the patient. Absolutely.
Excellent. And it does bring up a point that CPHA has been advocating for more decades than I care to remember, is that where you live in this country shouldn't determine your coverage for a vaccine, and your health data should be mobile with you, and it just isn't. And I did find it was great that during the pandemic that every province and territory created a vaccine registry for COVID, but now they can't do it for everything else. So it's an interesting situation. We received a number of questions around public funding and accessibility. And I guess the comment I can share about that is that we discussed before the webinar that it's being discussed in every jurisdiction. I think whether to expand or these programs and what the new NACI recommendations will mean in different jurisdictions. Certainly, it is a cost-benefit analysis the provinces do, and that's a big part of it. It's very mercurial and cold and numbers, and that's it. It's not about the individuals; it's about population-level impacts. But I did want to share with webinar participants. A study that the Adult Vaccine Alliance did last year around the unmet value of vaccines in Canada. So there's a link to that in the chat right now. But basically, looked at 6 different vaccines, one of which was the HPV vaccine. And for those 6, every dollar invested in adult vaccination, there's more than a 3 times value returned in health and economic benefits. So a return on investment at 341%. There's not a lot of interventions that have that kind of ROI. So if you in your jurisdiction, you could use this study for your internal advocacy for increasing coverage of HPV vaccine. So with that, we're approaching the end of the time that we have available today. I want to thank all of our panelists. Unfortunately, Dr. Warshawski had to leave, and I'm glad he did to get to his daughter's birthday party on time. But thank you very much, Dr. Cable and Dr. Duran, for being with us today. As mentioned previously, the recording of today's webinar will be posted to YouTube and to Immunize Canada's website. And before you leave, before you get on with the rest of your day, if you could take a moment to fill out a short evaluation, your feedback's really valuable in future planning of these webinars. Thank you all. Have a great day. Be kind to each other. Thank you.